Hello everyone. Today we are going to start with an important topic of pharmacology, drugs used for bronchial asthma, which comes under the topic of respiratory system. So, first we are going to look through the classification of drugs used for bronchial asthma. Once we understand how each drug works, it's going to be much easier for us to remember and understand the classification. So, we look at the classification at the beginning and also after the end of the lecture. Let's get started. So, drugs used for bronchial asthma. The mainstay of treatment here is the bronchodilators. In bronchodilators, they are divided into three categories. We have beta 2 sympathomimetics, which are selective beta 2 agonists, methylxanthines, anticholinergics. Beta 2 sympathomimetics, we have salbutamol and terbutaline, which are short acting, and we have salmeterol and formoterol, which are long acting beta 2 sympathomimetics. Then we have methylxanthines, which are theophylline, aminophylline, doxophylline. And then we have the anticholinergic drugs, which are inhalational. We take that from an inhalational way. We have ipratropium bromide and tiotropium bromide, which are mostly used along with beta 2 sympathomimetics. Next, we have leukotriene antagonists. These are montelukast, zafirlukast. Then we have the mast cell stabilizers, that is sodium chromoglycate, ketotifen. Then a most important class of drugs used in bronchial asthma are the corticosteroids. These have an anti-inflammatory action which is used against COPD and asthma, which are of inflammatory pathology. We have systemic and inhalational corticosteroids. In systemic, we have hydrocortisone, prednisolone, and in inhalational, we have beclomethasone dipropionate, budesonide, fluticasone propionate, cyclosonide. Then at last we have this newer mode of treatment, that is anti-IgE antibody, which is omalizumab. So here we can see the classification of drugs used in bronchial asthma. This might all seem really overwhelming right now, but once we go through each class of drug and understand about its mechanism of action, it's gonna get much easier for us to remember the classification of these drugs. So let's start with the most important class of drugs, the bronchodilators. First, we'll see about beta 2 sympathomimetics, which are beta 2 agonists. We have salbutamol and terbutaline, which are short-acting beta 2 agonists, and salmeterol and formoterol, which are long-acting beta 2 agonists. Beta 2 agonists are usually taken via pressurized metered dose inhaler. The short-acting ones, the action starts within 5 minutes and lasts for 2 to 4 hours. While the long-acting beta 2 agonists, they are inhaled twice a day, and these are mostly used for the maintenance therapy or nocturnal asthma, that is asthma that is exacerbated at night. They have a 12-hour action. So by twice daily use is sufficient when we are taking long-acting beta 2 agonists. Let's see the mechanism of action. Beta 2 sympathomimetics, they selectively act on the beta 2 receptor and stimulate them. Beta 2 receptor specially present on the bronchial smooth muscles and mast cells. When they are stimulated, there is increase in the cyclic AMP levels. Cyclic AMP is a secondary messenger. It is present intracellularly, and when the levels increase, it causes some changes in the calcium metabolism, which inhibits the muscle constriction in the respiratory system. So bronchoconstriction is inhibited, which ultimately causes bronchodilation. It also promotes mucociliary clearance and reduces the release of mediators from mast cells, since the drug acts on bronchial smooth muscles as well as the mast cells. These are the mechanism of action, how this drug works. Also being highly selective, it has less cardiac side effects. The adverse reactions for beta 2 agonists are muscle tremor, palpitation, restlessness, nervousness, ankle edema, And the most important complication of beta 2 agonists are hypokalemia. It is the most important complication. So when patients are on these drugs, beta 2 agonists, we should always check for the potassium levels. The long-acting beta agonists inhaled are mostly combined with inhaled glucocorticoids. We'll read about glucocorticoids later, but these are an important class of drugs used in the treatment of asthma and COPD. And if we combine them with these long-acting beta agonists, we can reduce the dose of steroids needed by half. Combining LABA with glucocorticoids causes double dose of corticosteroid action. So that's why we do not like using a lot of corticosteroids because it has a lot of side effects. That's why using it along with this drug reduces its dose and increases its action. So we combine them for synergistic effect. Then we have the drugs, the methylxanthines. These are from the same family as of caffeine, theophylline and aminophylline. Theophylline is 1,3-dimethylxanthine, while caffeine is nothing but 1,3,7-dimethylxanthine, trimethylxanthine. So let's see the mechanism of action. Methylxanthine inhibit the enzyme phosphodiesterase, which helps in the hydrolysis of phosphodiester bond in the ATPs and GTPs. So it causes increase in the levels of cyclic AMP and cyclic GMP, which is the similar mechanism of action as we saw here in beta 2 sympathomimetics. So ultimately it causes similar effect of bronchodilation, inhibits release of mast cell mediators, and improves the mucociliary clearance. But along with that, it has another action. Methylxanthines cause blockade of the adenosine receptors, which causes relaxation of smooth muscles and thus bronchodilation. Now, what can be the adverse effects of methylxanthines? They are a very good cardiac stimulant and gastric irritant, CNS stimulant, mild diuretic, and they cause smooth muscle relaxation, which causes vasodilation. Here we can see the effects are similar to that of caffeine, right? If we take a lot of coffee, we can see effects like CNS stimulation, cardiac stimulation. So the adverse effects of methylxanthines are similar ones. It causes smooth muscle relaxation and vasodilation in most systemic vessels, but not the cranial vessels. In cranial vessels, it has a vasoconstrictory effect, which is why this drug can also be used in the treatment of migraine. Okay. So that was about methylxanthines. Next, we come to the anticholinergic drugs. These are ipratropium bromide, tiotropium bromide. Ipratropium bromide is a short-acting drug, acts for 4 to 6 hours. Tiotropium bromide is a long-acting drug which acts for 24 hours. Tiotropium bromide is more effective in case of COPD. Mechanism of action. These selectively block the acetylcholine action. Acetylcholine, as we all know, is a neurotransmitter, excitatory neurotransmitter. So it blocks the action of acetylcholine and causes bronchodilation. Specifically, it acts on the M3 muscarinic receptor. Inhaled anticholinergics along with beta 2 agonists, they are more effective in the treatment of the asthma and COPDs. They are more effective and have a longer lasting action of bronchodilation. This synergistic action is used in termination of severe exacerbation of asthma or COPD. Duolin is a clinical formation which is most commonly used as nebulization in treating the patients of COPD and asthma. Duolin is composed of salbutamol. Duolin is composed of salbutamol and ipratropium bromide. This is an important composition you should know about.